Hi, Dr. Williams. Thank you for your time so much, and thank you for your work.
Thank you.
We just spoke about current cancer treatment,
Yeah.
and so you said that actually you can cure 100% of
Uh,
cancers.
I think we can cure, basically most. Particularly, the thing is that there's different situations, right? So,
Sure.
if we can start the treatment at the time of the biopsy, like so you identify cancer, you stick a needle in it, you should start treating it with immunotherapies and other technology right then. That's going to help you cure most cancers right off the bat, right from the start. Now, once a cancer spreads, it gets a little more complicated. Now, can you bring these people back? Yes, but it's much harder. When they have more advanced disease, then you've got to use like lots of combinations and you got to use multiple treatments. It's going to be a much more complex process, but still winnable, right? I mean, you can still do it. For the most cancers, with a rare exception, you can get the immune system to attack it. You just need the right combination of drugs.
Mhm.
And so what we'll do is like we'll use like because we're putting in a tumor,
Mhm.
so we can use 8, 10, 12 drugs. Sometimes I use 16, 20 drugs at a time. Which is would be you wouldn't think about that, right? Systemically,
Sure.
but in the tumor you can do that because you're trying to affect all these different things, and so you can get away with it at lower doses in the tumor. But that's where you want to create that immune response, and so that's what we're seeing. That basically with that we can treat a lot of these. There are a few rare cancers that we run into that they have almost such tight control on the
Mhm.
immune system because basically the immune system is what I'd say I call it the architect and the constructor of the body.
Mhm.
I mean, so whoever controls the immune system controls the body, and cancer tries to take over the immune system. If the cancer has a hold on it, and the immune system is really protecting the cancer, and may want to protect the cancer more than your own body in certain cancers, that's that way, and those are really difficult. You have to try to undermine them differently. Fortunately, that's rare. Most cancers, don't have that type of control in the immune system to where you can still undo it and get the immune system to see it and attack it.
Mhm.
But you got to hit all the different receptors. You got to get things to recruit the immune cells to see the cancer. And then they got to see like the pieces of the cancer, the antigens, and then you give it stimulation,
Mhm.
and then when the immune response starts, then the cancer's going to try to fight back, right? So it's going to do things to try to shut it off, and then you got to block those.
Mhm.
So it's kind of a sequence. Like you do this first part where you're recruiting the immune cells, second part where they're there now, you push them to attack, and then the other part where you allow them to finish the job by
Mhm.
blocking the cutoff points. Like
Mhm.
like the PD-1 is a good example. Keytruda, Opdivo, those
Yeah.
drugs. That's a checkpoint. But there's many others. So, there's TIM3, LAG3,
Mhm.
ICOS, Vista. There's
Yeah.
all of those, and sometimes you have to hit all these pathways.
Yeah, but speaking, it's like simply for the patients, like so if they get to you, like you had 100, you have had hundreds of patients, right?
Right, exactly.
So if a patient come to you in Mexico and on a stage 2 any
Yeah.
type of cancer, you can get like almost 100%, and if it's stage 4, it's like
I would
60%.
say, yeah, I would say that's probably about right. Yeah, I mean, I think you give somebody early, I can almost guarantee
Yeah.
that we should be able to cure that person. If you give me somebody that's late,
Yeah.
depending on the situation. I mean, a lot of it depends on what treatments have they had. Sometimes their treatments have impacted them so much that it's
Yeah.
hard to overcome that.
And it's interesting to suggest them to come to you first before
Oh.
they go to convenient.
I mean, ideally, we want if you have like a potential suspicious mass or tumor before anybody sticks a needle in that,
Yeah.
come to us because we will stick a needle in, but we'll treat it at the time, and that will change everything. Because if you stick a needle in a tumor, what happens is that when we biopsy these things, this is shown. There's a study published last year that showed that it inflames the tumor.
Yeah.
It changes the immune response. It causes the immune system to actually be more protective of the cancer, and that is what's contributing to metastasis.
Even before biopsy.
That's at the biopsy. The biopsy is actually worsening.
No, people have to come before biopsy.
Oh, right, this is
So,
right.
but
They
that means
should.
they're not as I understand, you can
So
diagnose.
we diagnose at the time of treatment. So what we'll do is we stick the needle in the tumor,
Okay.
and we will sample it, and we'll confirm, and then we treat. all the same
So
procedure.
you say if someone has an MRI test
Yeah.
that it shows like that it
Yeah.
might be a tumor,
Yeah.
even for biopsy test, they should travel to Mexico.
Yeah, exactly.
Okay, this is interesting. And so, how much it's an average? Can you speak about prices? Like, what's people
Yeah, I
have
mean,
to?
I think it's variable. I think as I told you earlier, like if you have a patient that's like early stage that doesn't have much going on, you treat them right in front. That's like $35,000-$45,000 probably, maybe 50. I'm not sure, somewhere in that range. But then at an advanced stage,
Yeah.
that's much more complicated. Then you're getting into hundreds of thousands of dollars,
Yeah.
to $250,000-$350,000 easily.
I see. Yeah.
It could be more
Sure,
depending
sure.
on the patient situation. Sometimes we look at that because like we have resources, but like what's difficult for the patients. I mean, some of the patients maybe they have money, maybe they don't. A lot of times we're helping try to support their care. We're paying for a lot of these drugs that the
Yeah.
patients are not actually paying the full cost of. And so sometimes like I say, well, I might could win this case, but I can't afford.
Yeah.
I can't afford to spend like $2 million on
Yeah,
that
sure.
one person. Maybe it would work,
Mhm.
but it's unfortunate. But when you get the cases that are advanced, you get some of those that are like that, where the investment of money is going to be so much that it's going to be really hard to manage.
Yeah, this is and the last question that I have to you. It's very. I just don't want to take much of your time because we are in a conference. But the last one that I would like. This is very interesting to like. It's mostly like people from longevity field who watches my videos. So this is interesting that you're taking like partial chemical
Yes.
reprogramming molecules to yourself for
I am.
rejuvenation and for the cancer itself. Could you
I
elaborate on
am.
it?
So yeah, so it's interesting. So obviously, I followed heavily the work of David Sinclair,
Yeah, sure.
his chemical reprogramming, and the thing was that so Sinclair, I knew him for a while, and I was looking at his stuff and I was looking at my stuff in cancer, and I was like, these things are looking similar. He's using similar stuff. I'm using the same type of stuff, and like, well, this starting to come to be like cancer and aging are almost the same disease, right? And they sort of are in a way. What I was seeing is that some of my cancer drugs, when I was getting the immune response, was making the tissues younger, making the patient younger, and so I was like, that's interesting. So it's the immune system that helps keep you young. But certainly the reprogramming, the idea like with David Sinclair with the information theory of aging and this loss of the DNA copies and being able to kind of bring that back. That's one component, but there's an immunological component because it's the immune system that actually like fixes things and makes you better. So you have to do both kind of together, and that's what we're finding. So it's like you do a reprogramming, but you need to do an immunotherapy with it to make it work.
To make a person young again, so
Exactly.
it can be protected. But what do you feel? Can you say any effects on yourself?
Oh,
You have
yeah.
been taking on 2 years.
So about almost 2 years. Yeah, December would be 2 years, and
This partial chemical reprogramming.
yeah, exactly. So it's amazing. So because I had to test it on myself to know.
Yeah,
And
2 years. Wow.
Yeah, so initially my idea was that I had a goal. I wanted to save my mom. My mom was 80, and I was like, I wanted to make her like younger. And so initially I talked with her, and she was like, yeah, like do whatever you want. But then I was like, I don't want to give my mom something and like kill her. I'll feel responsible, right?
Yeah, sure.
So I said, I've got to test it on myself. So I decided I'm gonna take it. So I did the work with like some of the chemical reprogramming, like using the model from David Sinclair, but then we modified it with some of the immunotherapies, and that because we tested just like doing the chemical reprogramming alone. We've done it in some patients, and then it works, but very mild. The immune system fights against you. Where so Sinclair's work obviously worked well in mice. And we were able to translate that into humans. We just need to modify it a little bit more to make essentially what his therapy does to work in humans. And so it's just a little bit of tweaking to the immune side of it. And but yeah, the thing is that I felt it. I mean, I took it. I was like, oh my gosh, no, I'm getting younger, and I start feeling my face. It felt different.
You're 51, right?
Yeah, 51. Yeah, I mean, I was like, oh my gosh, like I'm getting younger. I mean, I know it. I know it. I don't have to have like particular markers. I feel it. I know that I'm getting younger. I feel that way. I mean, in many of the things, it's interesting because like part of this is a blocking of like TGF beta and blocking IL-1. If you look at those things, TGF beta can be a real driver of depression. but you block it, it makes you happier. And it's like, you know how when you're younger, you were happier.
Yeah.
Well, when you take this stuff, it makes you happy. I mean, I feel like happier. I have a different interest. I mean, I feel more like childlike.
Mm.
And when I take the therapy, it's like I feel like I want to go outside and play. I want to ride my bike and like do stuff that I did when I was a kid.
Yeah.
I mean, you have that same feeling, so it's amazing.
How's your mom?
She's doing good, yeah. So I have her on therapy. She's not as on an aggressive pattern as I'm on. I'm a little bit more. I want to see how far I can go. So I'm 51. I would say that over this almost 2 years, I probably reversed my age about 7 years. I'm thinking that 3 to 5 years per year is probably what we can maximally do. I mean, maybe you could push it, but I'd say that's kind of doing it full out. And so I'm going back, and definitely getting younger. And I would say definitely from 51, I'm certainly like 44, 43, and but in another year I'll be like 37. And another year after that, I will be like 32.
Yeah, like Benjamin Button.
Yeah,
Yeah,
exactly, exactly.
And so you have it's not just for yourself and for your mom, so it's also for patients.
So this is the thing is that we found that this sort of reprogramming and this immunotherapy stuff is very anti-cancer because the cancer and the aging are similar, particularly the senescent cells. They express a lot of the same receptors as cancers, and cancer ages all the cells around it, uses senescence to kind of help disguise itself from the immune system. And so that's the thing that was interesting with it, is that when you do this, when you treat these, you're treating the cancer, and you're also like reversing the aging. And so yes, it's an interesting.
But you also give it to healthy people, right? And
So
for example, with myself,
we so we want to start a trial where we want to look at spine. So we degenerative spine as being sort of the measure, and we want to look at like disc regenerating and things like that. And that's going to be like our target. And that's what we're looking at more in people who are technically healthy. I mean, at least don't have major problems, but they do have disc degeneration. We by the MRI.
But but you're a doctor, and I'm a healthy person. Would you like give me like partial chemical reprogramming? Can I come to you in Mexico to get it?
I mean, so we're not ready to give it out to everybody yet, but we'll be in the future we'll be able to give it out to more people. Right now we kind of keep it more for just like some of our initial pretrial patients, and then some of our cancer patients, because this therapy is super protective against cancer. So you can get cancer knocked down, but then when you give this, it makes you very resistant to cancer. So for example, David Sinclair did the work where when he puts the mice on these reprogramming factors, he tries to give them cancer, can't give it to them.
Wow.
Yeah, they fight it off.
Fascinating. Yeah. Okay. Thank you so much.
Oh yeah. Thank you. Yeah.